Thank you, ma'am. Our next speaker will be Dr. Mudit Tyagi, and he'll be discussing the role of multimodal imaging in uveitic diagnostics. Does it add value? Does it make a difference? Dr. Mudit will tell us.
All right. So good afternoon. First of all, let me thank Samrin for having me as a part of this great IC, and to the scientific committee and the chairs for allowing me to talk on this. So I will be talking on the role of multimodal imaging in uveitis. Does it add value and does it make a difference? Now, what do we mean when we say multimodal imaging? What that essentially means is when different imaging scenarios, different imaging modalities come together, whether it's in the help of a fundus photograph or an autofluorescence or an OCT, FFA, dye-based angiography, ultrasound B scans, when all of them come together cohesively and help us in identifying and in treating our patients. So that is what multimodal imaging essentially means. And how can we use multimodal imaging in uveitis, and what is its role, and how much of an advantage does it give to us as clinicians is what we will see with the help of a few examples. Let me start first with this very basic early simple slide, but before that, what are the roles and how do we use multimodal imaging in our clinics? The first and foremost role of imaging is number one, to identify what we are dealing with. What's the disease that we are dealing with? So it helps in identifying a lot of our diseases, identifying the extent of the disease involved and also the pathogenesis, what's happening as far as the disease is concerned, the activity of the disease, and sometimes subsequent complications that can ensue in the course of the disease. So those are the scenarios where imaging comes to our help. So let me show you first a very simple example. This is a slide which has been shown to us by Dr. Avinash Padange, and I owe this slide to him. So this is basically how do you differentiate on clinical and imaging analysis between retinitis, choroiditis and a posterior scleritis on the basis of an FFA alone. So two important points. Look at the intensity of early hypofluorescence and the pattern of early hyperfluorescence, and I will come to that with example. So in retinitis, the intensity of early hypofluorescence is the maximum, followed by choroiditis and then scleritis. And look at the pattern of early hyperfluorescence. So early hypo and early hyper. Look at the intensity of early hypo. Look at the pattern of early hyper. If it is perilesional, you are dealing with a retinitis lesion. If it is intralesional, choroiditis, and scleritis, as we all know, will have pinpoint lesions. So let me show it over here. So this was a patient with retinitis. Look at the early hypo. The early hypo is the maximum over here in retinitis as compared to what you see in a choroidal lesion over here. But look at the pattern of the early perilesional hyperfluorescence. So there is a perilesional hyperfluorescence that occurs in a retinitis. As compared to that, in a choroiditis, what you see is a diffuse intrastromal hyperfluorescence. So early hyperfluorescence is perilesional in retinitis and intralesional in choroiditis. And scleritis, obviously, like we have discussed earlier, will have multiple pinpoint leakages. And when you add to it an ultrasound B scan which shows this characteristic subtenos fluid and what we describe as a T sign, all of those come together to help us arrive at a diagnosis of a posterior scleritis. So just based on imaging, we are able to arrive at what essentially are we dealing with. Is it a retinitis or a choroiditis or a scleritis? Moving on to some common diseases that we encounter in our clinics. If you look at this eye over here, what you see is a placoid chororetinitis with intense infiltration at the edges. Now clinically we have learned to identify this pattern as being something which is characteristic of ocular syphilis. But when you add an OCT to your clinical examination, what you find is this diffuse RP nodularity. So you put both of these together, an OCT which is showing RP nodularity and photoreceptor damage, and a fundus photograph or a clinical appearance of a placoid chororetinitis. Both of them come together and help us at arriving at a diagnosis of the fact that we are probably dealing with ocular syphilis. So it helps in narrowing down our differentials. It helps us in arriving at the etiology of what we are dealing with. Similarly, you see these multiple miliary lesions. Now, miliary lesions have been actually described in different uveitic entities. There are people who have even described it for sarcoidosis. But once you do an OCT through these miliary lesions and you see a full thickness retinal involvement, that is pretty characteristic of syphilis again. So you see these multiple miliary lesions and you see an OCT passing through them showing a full thickness retinitis. Again, it clinches our diagnosis as what we are dealing with is syphilis. So again, multimodal imaging helps us in arriving at the diagnosis of the underlying disease. In terms of retinitis lesions, when you do an OCT, you see this area of necrosis, but you see predominantly not only the extent of involvement in terms of the layers of the ocular area which are involved. So you see a full thickness retinitis, you see some amount of fluid over here, but you also see a choroidal involvement. And when you see a retinochoroiditis, you can differentiate it from the other lesion, which is a viral necrosis. And in viral retinitis, usually you will not see a predominant choroidal involvement. So you get an OCT done, you see a choroidal involvement along with the retinal involvement. It helps us in differentiating between a viral retinitis and what you're dealing with in terms of this being a toxoplasma retinochoroiditis. Similarly, in inflammatory diseases like VKH, when you see these multiple neurosensory detachments, adding an OCT helps us in appreciating these RP undulations, hyperreflective dots in the choroid, and that kind of helps us in assessing the fact that this is a case of VKH. And I'll show you how OCT also becomes important in assessing the response to treatment in some of my next few slides. Also, there are occasional times when you may have a diagnostic conundrum. Sometimes, very rarely, a multifocal CSR also may mimic a VKH. And therefore, looking at subtle signs like fibrous septa, RP undulations, choroidal granularity, along with absence of pachychoroid, helps us in differentiating the fact that we are dealing actually with VKH and not with a multifocal CSR. The diagnosis will also help us in determining a treatment. Steroids obviously are contraindicated, or rather not to be given in CSR, whereas they will be the treatment of choice in case of VKH. So it's important for us to differentiate between these two entities, which may both present with subretinal fluid with some neurosensory detachments. So like I said, how you differentiate acute VKH from acute CSR, you see these RP undulations over here, you see some inflammatory signs, you see this neurosensory detachment and a bacillary layer detachment. All of those will be absent in an acute CSR, and that will help you in differentiating between these two entities. Some more disease where multimodal imaging helps us in understanding what is actually happening to the disease. So this was a patient with a progressive outer retinal necrosis, and what we found was a full thickness retinal involvement with extensive necrosis. This was a kid who was immunosuppressed, was treated subsequently with gencyclovir, but OCT very clearly helps us in assessing the layers of the retina involved. So the point which I am trying to make again and again is that imaging comes to our rescue not only in identifying the disease, but in also understanding what are the layers of the retina and the choroid and the uveal tissue which are involved, and can then help us in arriving at not only our treatment diagnosis, but also in tailoring our treatment accordingly. So one more case, this was a patient who came with a history of fever a month back, now comes to us with these multiple hard exudates, some area of fluid, one area over here of these subretinal and preretinal hemorrhages, one small area of retinitis. And when we did an OCT angio, what we found was this angiomatosis over here, which could be very nicely delineated on this OCT angiography. This was a case of Bartonella, which was treated subsequently and responded. So OCT angiography over here helped us in appreciating this angiomatosis and arriving at a diagnosis of Bartonella. One more very interesting case, this was actually a high myope patient who had presented to the clinic with a decrease in vision in the left eye and was initially suspected as having a myopic CNV in the left eye. But the point to note over here is that what is happening to the right eye? The right eye vision, and now the patient tells us, has gone down in the last 1 week from 20/30 to 20/1200, improving to 20/400 on pinhole. And now when you do an imaging, this is what the autofluorescence reveals. A diffuse area of hyperautofluorescence. This was a patient who was having an RP epithelitis, and this patient was subsequently, because he was not responding and the lesions were not regressing, treated with systemic steroids. And let me show you what happens after some time to these lesions after we started the patient. But the point is that if you look at this photograph, you see the vision has gone down, and while you may appreciate that there is a small faint lesion over here, an autofluorescence very brilliantly demarcates what is happening, and we have seen some beautiful images of subregions like choroiditis in the previous talk. So these imaging modalities help us in appreciating also the extent. So let me show you what happens over there. But the OCT through these lesions again showed this RP nodularity and some damage happening at the level of photoreceptors. So that is how multimodal imaging can help us in arriving at a diagnosis of what is the disease that we are dealing with. Moving on to the fact that it can also help us in appreciating the extent of the involvement and the extent of the inflammation that is happening. So this was a patient who was seropositive, came to us with a sudden decrease in vision, and you can see a very small subtle retinitis lesion over here. But when you do an autofluorescence over here, you can see the extent of involvement. This was a patient who had developed a toxoplasma retinochoroiditis. She is seropositive, immunosuppressed, develops a lesion now over here, which was, the PCR came positive for toxoplasma, was treated with Bactrim DS. But look at how brilliantly the multicolor imaging reveals the extent of the lesion. So while on a naked eye or just a cursory fundus evaluation, we may try to probably underestimate the amount of involvement. A multicolor imaging very nicely reveals the extent of the photoreceptor damage and the extent of RP damage and the extent of the lesion which has happened over here. This is how the OCT reveals this area of full thickness retinitis, some area of ensuing necrosis, hyaloid getting adherent over here. This patient was subsequently treated with Bactrim DS and did subsequently improve, came back with a vision of 20/20 finally, but is on a maintenance dose of Bactrim DS. Again, moving on to serpiginous like choroiditis, and in choroiditis, autofluorescence helps us in assessing the extent of involvement. We have now noticed that eyes which have got this extensive hyperautofluorescence at the edge of the lesion, or what we call the double ring of hyperautofluorescence, are eyes which end up having a higher propensity of paradoxical worsening, and also eyes which will probably need a long-term immunosuppression and a prolonged treatment duration. So autofluorescence not only helps us in identifying the extent of disease, it can also help us in identifying and tailoring our treatment approaches. Moving on to activity and complications. We have already seen the role of autofluorescence and OCT in identifying the disease. Let me also show you how OCT angiography can actually help. So a choriocapillaris regeneration is a sign of healing. So when you do an OCT angiography through these lesions, what you can see is this area of healing edge, and this area can easily help us in assessing the fact that our patient is now responding to treatment over here. So choriocapillaris recovery has been described very characteristically as a sign of healing of these choroiditis lesions, apart from autofluorescence patterns which we have already seen. Also in eyes which of weak age, a lot of times your patient may have a good visual acuity but may come with a sudden decrease in vision, and while on an examination you may not find anything else, but you will find a thickening of choroid in some of these cases. And apart from thickening of choroid, ICG angiography, though I have not shown an image over here, will help us in appreciating these multiple small granulomas. So ICG angiography in cases of chronic weak age is a very important tool in assessing the persistence of granulomas, which will help us in determining or deciding whether we need to stop immunosuppression or do we need to continue with it. And along with that, if new granulomas are appearing, then it's a clue to the fact that we need to step our immunosuppression. So again, imaging comes to our rescue in assessing our response to treatment. So we were discussing about VKH earlier, and resolution of RP undulations is one of the first signs in assessing the treatment response to VKH. So this was a patient of VKH. The moment the patient was started on steroids, I'll just take one more minute. You can start seeing the regression of these lesions over here. Similarly, you can assess the response to treatment in case of this toxoplasma retinitis that we had seen earlier. The lesion starts regressing, but even on OCT, you can see the fluid regressing, the retinitis regressing, and eventually a scar formation that happens over here. One more very important investigative modality is OCT angiography in assessing the presence or absence of inflammatory CNVM. So you may have patients of choroiditis who have got a quiescent disease, that there is no activity, but may suddenly come with a decrease in vision. And because of the scarring and the complexity caused by the underlying inflammation, you may not be able to appreciate some of the subtle CNVMs. But an OCT angiography very brilliantly will pick up the fact that there is an underlying inflammatory CNVM, and then your treatment will also involve anti-VEGF injections and not just the control of inflammations. So the last point, if you remember the case of RP epithelitis that we had discussed, was started on steroids, and now autofluorescence can be used to assess the response. Look at how the autofluorescence starts regressing, visual acuity reduced, improved from 2400 to 2060, subsequently 2030. So this is how the patient was at presentation, 1 week, 2 months, and at 5 months. So essentially, imaging also helps us in monitoring the response to treatment. So in a nutshell, multimodal imaging helps us in not only identifying these diseases, it helps us in understanding the extent of the disease, and also in assessing the disease activity and complications and response to treatment. Thank you so much.
So thank you, Mudit. I think you've shown some beautiful examples of various cases of uveitis. And I think one important message which comes out of your entire presentation is that one is that we should not feel handicapped if we don't have expensive imaging modalities. I think 80% of our uveitis cases we can diagnose and manage based on our clinical examination and our index of suspicion, where we should have a differential diagnosis. I think it's only 10 to 20% is going to be contributed by various imaging modalities and lab investigations, which can help us to confirm what we are clinically suspecting. And there can be very subtle things which can be confusing when we do a clinical examination, and probably that is where we need to clinch the diagnosis based on the multimodal imaging that you have shown.
Exactly. So most of these diagnoses, and lot of these points are clinical clues. Once we start getting into the habit of assessing this, and I believe a fundus photograph, autofluorescence, and OCT are predominantly now available in lot of our ophthalmological uses. So while we may say that OCT angiographies and ICGs may be something which may not be there with everyone, but a basic fundus autofluorescence and fundus photography is usually very easily available. And not on, even if that's not there, a good clinical evaluation and picking up these clinical clues in itself can help. So imaging will probably come, like you said, as an addendum to our clinical clues and can help us in overcoming some of the dilemmas.
Definitely, Dr. Mudit. There is no substitute for a good clinical examination because we have such a huge array of investigations and diagnostic modalities available that you cannot apply everything to a case.
True.
You first clinically assess and then you decide what you're going to be using in your case.
Exactly.
So thank you for beautifully bringing out the ways how we can use these modalities to diagnose our patients effectively. Thank you so much.
Thank you so much.
Now,